last talk is certainly a talk that I think a lot of trainees will have a huge amount of interest in. We're very honoured to have the medical director of Medical Protection Society, one of the indemnity organisations here in the UK, and also one of our main sponsors and supporters. Uh, they do lots of great work. We have been putting it out there in the chat, some professional development courses that MPS run, and true to their ethos, it's not only for their members, it's also open to non-members. So please check out the link, the information in regards to the indemnity that they offer for newly qualified GPs. And I appreciate Rob's been waiting patiently all this time. So apologies, Rob, and thank you for giving up your time to give this talk.
No problem at all. Pooja, a real pleasure to join you. And actually, I tuned in early because I was really interested to hear Anshuman's talk, which I thought really was quite inspiring. And I just want to echo the fact that, a training in general practice really does open doors to doing all sorts of things. My own background is as a GP, and I developed an interest in medical legal work, which took me into this place. But I think as GPs, we've got a range of skill sets and opportunities to develop in different ways. So what you've just heard, I think, is really good. And again, I think the importance of taking control sometimes of your career and the way you work can make a lot more pleasant and perhaps fend off some of the worries of burnout and so forth that we hear about. So what I was planning to do, and probably the first thing I should do, I don't know if you can see me, but I probably should apologise for my slightly strange moustache. I'm taking part in a sponsored moustache growing thing for Movember, and 12 days in, it's not looking great. So I've had a few complaints about that at home, but there we are. Anyway, what I was really wanting to talk a little bit about this afternoon was about complaints. And it's really more to think about how can we avoid them, and are there things you can do by taking back a bit of control on the situation that can avoid these rather negative events. As Pooja says, I'm the medical director here at MPS, and we work with doctors, dentists, and other healthcare professionals around the world. And as well as indemnifying them for claims where that's necessary, we're very keen to work with people, both a bit of education, but also advice as and when things go wrong. These are the main markets we work around the world in. And what's quite interesting is the similarities in the kind of issues doctors and GPs face in different jurisdictions and in different cultural settings. And there's an increasing body of evidence growing around the reasons that patients complain and how best to head that off. I'm not going to go through this in any great detail, but as GPs, we face multiple layers of accountability, whether people want to just simply complain to you or the practice, make claims for negligence, or involve people like the GMC. And as you know, I was reading my BMJ just before I joined you. There's a lot of concerns about the way the GMC is performing at the moment. And other people will be interested in the care you deliver to patients, whether it's coroners, occasionally the police, and increasingly the press and the media and social media. But I think what I'd like to talk about really is the underlying issues for how these problems arise in the first place and how you might be able to head some of them off. So what is it patients actually want? And there's been quite a lot of research done surveying the public about what is it they expect from their GPs. And interestingly, top of the heap often comes clean. And I think this was really off the back of COVID and the fears of people attending practices and surgeries, the fear that they might catch something. But there's no doubt that the way up your surgery, waiting room and so forth is set up can get things off to a good or bad start. They also want doctors to be competent. You know what you're doing. They want you to be able to communicate with them, and they want to be involved. We talk a lot about consent, but I think a lot of that is about patients want to be involved in decision making around their care and the options available to them. And increasingly that may be doing nothing, or maybe doing something outside mainstream medicine. They expect you to keep the material you tell them confidential, and they expect doctors to behave like doctors. And that's a whole interesting subject, and I think one of the areas the GMC sometimes get themselves in some difficulties with. As I say, not all patients who have problems complain, and there's been a lot of research done to try to identify why it is some people complain and the majority don't. Now, this is hospital data, but I think it's extractable to primary care as well. And we know that a lot of patients will suffer adverse events when they're in hospital. Probably about half of them are probably preventable, but relatively few, only about 1%, would actually be negligent if you were to take it to court. But the interesting thing really, and I think it is something to think about generally, is that very few people who actually suffer clinical negligence ever take any actions. And it's often estimated at less than 5%. So there does seem to be something going on that triggers some people to complain or take legal action, when most of the time, most people don't, even when there's been a problem. And stacking back a bit, a lot of complaints, and I suppose it's not just in medicine, but generally, is something to do with unmet expectations. Unmet expectations, rather. So if people are expecting one thing, you don't get it, that's where disappointment arises, and that often triggers the complaint. And if you think about your own experience, whether it's in a shop or restaurant, whatever, it's when your expectations are unmet, you're going to be unhappy. So actually identifying and thinking about what patients' expectations are when they come to see you is actually quite an important risk management strategy. So as well as just thinking what's wrong with the patient, what's the clinical need, and what's the clinical management I need to think about, it is worth thinking about why have they come here today and what is it they actually want. Now, whether you ask them that or come at it in different ways, I think is important. Because in my experience, relatively few complaints or referrals to the GMC or so forth actually arise from a lack of clinical knowledge, clinical errors. It's rarely that somebody's forgotten their pharmacology or that their physiology has got a bit rusty. It's very often about patients not getting what they want or taking exception to the way things have happened. And there's good evidence that communication is not just after events that have gone wrong that lead to people taking action, but it's actually the communication that you have with your patient before anything happens is important. Because when you think about it, patients can't really work out whether you're a good doctor or a bad doctor, but they will form a view from within a few minutes of meeting you whether they think you are good and are competent. And they'll extrapolate that view into, does this doctor know what they're doing? And we know from the research that patients who do take action against doctors, whether it's complaints, whatever, are often ones who have a perception of poor communication before something goes wrong. So if they think that you're not interested in what they're saying, so there's a lack of empathy, lack of information. If something were to go wrong, they'll say, I'm not happy. I knew he wasn't listening, or I knew she wasn't paying attention to things. So that's really quite important that that impression is created effectively early on. And the other thing that seems to drive people to make complaints is a feeling of disempowerment, sense of being devalued, not taken seriously. And interestingly, when things do go wrong, patients will often say one of the reasons they felt bad was that they felt deserted, they felt abandoned, they felt the family were excluded, or the staff were arrogant. And one of my colleagues, I think, talks about if something does go wrong, to run towards it. And I know, again, from my own days in practice, I can think of a number of examples where I made a mistake. I felt pretty awful about it, but actually, if you're able to come across as a concerned, going to see the patient or their family or whatever, made them feel that you were giving them support, and actually the patients often and their families often can end up comforting you. So whilst it can be a bit embarrassing and a bit awkward, going to see somebody if you've heard that they've run into problems, or saying I can't speak to anybody, it can simply come across as a lack of empathy or arrogance. And I know you were talking earlier about burnout and so forth, but a lot of these traits, if you like, this sense of not listening or being non-empathetic to patients, often is a way in which doctors who have burnt out can come across to their patients, which does make them more at risk of complaint and other action. So good evidence, and there's a number of references here, but as patient satisfaction goes down, the risk and the number of complaints and litigation goes up. And Rodriguez there again was looking at what was it about doctors who avoided complaints, because a lot of large studies, particularly in the States, looking at the traits of doctors who seem to get complaints and other ones who don't have them. And the people who were doctors who were getting less complaints, had significantly less complaints, were ones who explained things clearly. Patients believed they were giving them enough information. They came across as caring and kind, and they knew something of the medical history. And I think that's quite an interesting one, particularly as trainees, if you're in surgeries where you don't necessarily know the patients or get to know them. It is worthwhile just taking a little time to know something of their past history from the records and so forth, because again, that gives the impression that you're concerned about them as individuals and you've taken some time to acquaint yourself with their history. And this is obviously an important one about spending enough time with your patients. Patients feel rushed, often are dissatisfied. And as Anshuman was saying in his previous talk, one of the advantages, I think, of taking more control over how you communicate with patients is actually just getting enough time for it. And 7.5 or 10-minute medicine, I think, is becoming increasingly unsatisfactory, not just for patients, but obviously for doctors as well. And I think there's a lot more pleasure in having a sense that you get to know your patients and can spend time with them to really get into their concerns. So kind of just going back over some stuff here. These were predisposing factors in this study. So these were looking at patients, and they were actually, the majority of patients who complained said that they decided they were going to complain if something went wrong before it went wrong. And again, it was a perception of rudeness. And I think that's why we can be dependent on our staff to make the surgeries welcoming places where patients feel comfortable. But a sense of apathy, disinterest, inattentiveness was described as these predisposing factors. So where patients are exposed to that, if then there is a precipitating factor, they get an adverse outcome, or perhaps of a side effect of a drug or whatever. And if you do make a mistake, and we all do from time to time, there is no doubt that patients who've been predisposed to making complaints are much more likely to take them when these precipitating factors kick in. So what can you do to reduce the likelihood of complaints? Again, some of these are personal and some of these are at practice level. And no doubt, from what we've said, it's important that you behave in a professional manner. And by that, it means coming across in the way we've discussed, giving a sense of interest, empathy, and so forth. I think self-awareness is important, because sometimes you'll know already in your training, sometimes you'll be speaking to a patient and you just think, this isn't going so well. We don't seem to be gelling here. They don't seem to be communicating, and just identifying that, almost having that sixth sense where something's wrong. Or perhaps a parent is more anxious about a child than the clinical picture really indicate. So having that sort of situational and self-awareness, I think, is important. And of course, you then become very dependent on having decent clinical systems to back you up. The mistakes that often we see are where there's prescribing errors. The interface between primary and secondary care is a real difficult area. You know, if patients have either been discharged from hospital or been referred back from the clinic with changes in medication, if there are errors in the way that those systems pick them up, and you're often reliant on ancillary staff to be putting in data into the computer system and so forth, but that can give rise to problems and complaint. And again, patients will often think, if their underlying impression is that you're a bit slapdash, that the surgery is not very well organised, never really works very well, when a mistake is made in prescribing, they'll say, well, you know, we kind of thought that was going to happen. I'm going to complain about it because I don't want other people suffering. Again, making sure your systems and your staff are trained, particularly around confidentiality. And often it is at the reception desk or clerical errors, you know, emails being sent to the wrong patient, or people overhearing things being said on the phone. So taking a bit of time to think about how things are organized within the practice can make your life a lot easier. Another system thing, of course, is managing incoming data. You'll be overwhelmed. I know a lot of test results coming back, letters coming back from clinics and so forth, but making sure that you've got systems that support that and support you go a long way to providing or at least reducing the likelihood of things going wrong and complaints arising. And I wouldn't want to suggest that you don't want to keep your clinical skills up to date. I think, again, as the previous talks have said, making sure that you're getting plenty of time to do other interesting things in your life so that you are up to date with what's going on. But I think it is important that particularly if you're doing some procedural stuff, things like some aesthetic meds or whatever, that you have the basic skills, but also doing an adequate volume to make sure that you're good at it. Clearly, as you come through your training, you will be up to date. But as you go forward, again, I think one of the challenges as a GP, and I remember it very vividly, is where there's such a broad range of clinical information to keep up to date with, it really can be quite challenging. So I think thinking about that and think how your continuing education is going to go is important. And finally, I think one of the key clinical skills I'm sure you're already working on with trainers and so forth, but is around managing patient expectations. Because I think often as doctors, we're very keen to be people pleasers. We want to do what patients want, but sometimes we can't do that, or the system won't allow it, and particularly in the cash-strapped NHS that you're working at the moment. I think it's important to manage expectations as to what can be happening or what you can do for patients, so that when their expectations aren't met, there's less chance of complaint. Not going to a huge amount of complaint management, because there's lots of stuff out there, and I'm sure the practices you work in will have complaints procedures and so forth. But really just thinking about when things do go wrong, and you will pick up errors, sometimes even before the patients are. So if you realize there's been a prescribing error or whatever, it's important that you recognize it early, report it, and let patients know under the sort of duty of candor if something has gone wrong. I think the days where people hush things up have gone. It's really important you do that. And of course, if there is an error that needs rectification to prevent further harm, it's important that's dealt with. But where it has, where something unfortunate happened, I think it's really important to make detailed records of events as close to the time as possible. I'm thinking those horrible times where you come into the surgery the next day and you realize that somebody you saw that you didn't think much was wrong with them had been admitted as an emergency, perhaps, overnight by the out-of-hours service. And there's nothing wrong with going back. You certainly wouldn't want to make the records look in any ways if they've been tampered with, but particularly with electronic systems nowadays, that's much less likely. There's no harm in saying, look, I realise that Mr. Smith, who I saw and thought didn't have much, much wrong with them, ended up in coronary care. You want to go back and put into place an understanding of your events and what happened when they're still fresh in your mind. Because once you start speaking to others, once you maybe go and see the family, see the patient, your perception of what really happened and who said what to whom, it can become warped, if you like. So getting down a clear record as soon as possible is important. Certainly, I think it's important to speak to the patient and their family. I think there's often a myth going about that defence organisations say that you should never say sorry or apologise if you're aware of an error. That is completely not the case. And I know from personal experience when I was in practice, speaking to patients and their families, when you are aware of something going wrong, usually heads off trouble and allows you to actually build on the relationship. But it can be stressful having complaints or sense people are not happy with what you've done. So we would encourage people to speak to your colleagues, whether that's within the practice or within your trainee group. We would suggest you should be taking advice early. Another urban myth is that if you speak to your defence organisation that they will hold that against you. That's not true. We certainly are very keen to give members support when they've run into difficulties or had complaints and give you some advice as how to take that forward, particularly if you're thinking, should I be seeing the patient? Should I take somebody with me? How would we set things up? I say that it's important to apologise if there are reasons to be sorry, not to shy away from that. But it's very important if patients have had a bad experience that you take time to listen to them, make them feel they've been heard, and that their story, which you may not always agree with, and it may be subtly different, but that you're not trying to deny them their narrative, their version of the truth. And I suppose it's ultimately important that we learn from errors, because that's how I think as we as humans do learn. And equally, if there are systems errors you're picking up in your training practices that you think your colleagues can learn from as well, it's important that that's passed on. The JMC say that you've got an obligation to professionally to act in the way I've described where things have gone wrong. And there is now also the duty of candour legislation, which places a legal duty on you. We said there's really no need for more legislation in this because you always had a professional duty to do so. But people were keen to drive that idea that patients have a right to know what's going on if there's been an error. Again, I think it is important just to think about how you feel. Do not be surprised just how unpleasant it is and how stressful it is to have a complaint, even fairly minor ones. Nobody has had to die or come to any great harm, but being told by somebody that you didn't care for them or their loved one, that you were incompetent in some way, it really is like a dagger sometimes to us professionally, because you spend all your time trying to do the best for patients. And sometimes if you're going through difficult periods in your life, this can often be the last straw. And sadly, we do know that doctors and GPs sometimes struggle with mental health. So again, I think it's really important that you acknowledge that, speak to colleagues, speak to ourselves. We certainly provide a free, confidential counselling service for doctors. I know the BMA do too as well. But as GPs, we're really bad sometimes at seeking help and seeking support, because we feel we just need to absorb things when we get complaints, and that is not right. So once you've addressed the problem, and if patients complain or write in or whatever, again, you're probably going to find you will have systems within your practice, often administered by the practice manager, whoever, to make sure that the complaints are dealt with, that they're acknowledged within the prescribed time limits. And if you are asked to make comment or explain to people what you did, make sure you've seen the record. before you make comments. I think as doctors, again, we often sometimes rush trying to be helpful into telling people what you think happened, and then when you actually get a chance to look at the record, you find, oh, that's not quite what happened. And that then often looks like to people as if you're changing your story, or if you're trying to varnish things to your advantage. So take your time. If you can't remember what happened, and sometimes these complaints come in quite a long time after the event, take time to get the records, have a chance to reflect on what happened, the care, talk to your colleagues. Don't keep it all to yourself. And as I say, if you're a member of MPS, we'd advise you to take advice, get in contact with us. And if you are having to write to the patient, if they or their lawyers are asking for written comments, it's worthwhile thinking, would it be you? Would it be one of your partners? Would it be your trainer, or whatever? And obviously, if it has exposed an area of clinical or knowledge lack, then thinking about how you address that, rather than just thinking, let's deal with this complaint, let's get away from it, and let's forget about it, because sadly they may come back to cause problems again in the future. So just with an eye on time, really just some concluding thoughts. Some of these may be a little bit obvious, but it sounds trite to say it, but it's absolutely true that if patients like you, they're very unlikely to sue you or complain about you. So it is worthwhile trying to build relationships with patients. And I think as GPs, that's something that we can do more readily than some of our hospital colleagues. Errors part of medical practice. I think sometimes as doctors we can be a bit perfectionist, and if ever we make mistakes, we beat ourselves up. But you shouldn't do. Errors part of practice, but it's making sure you've got systems to try to minimize them and pick them up and deal with them when they occur. As I mentioned, complaints are not evenly distributed across the profession. We're not all at similar risk, that behaviours, personalities and approaches do put some doctors at more risk of having complaints than others. And I think it does behove us to recognise that. I think it's important for trainers to help doctors, perhaps, whose consulting style puts them at more risk, to address it, to try to reduce that stress and unpleasantness. We've talked a lot about putting systems in place that will reduce your risks as far as possible in practice, and the importance of focusing on patients' expectations. But I can't stress this enough. I think it's important that you do look after yourself and that you look after and support colleagues when these unpleasant things come along, because I think if you do that, you will get far more pleasure out of what should be an exciting and worthwhile career. So if you're interested, we've got some more material on our websites around some practical issues around risk management and so forth. And for members who are tuning in today, be interested if you want to pick up on some of that stuff. Obviously, you can go to our website for more information. But really, Pooja, that was all I was going to talk about this Saturday afternoon.
Thank you, Rob. A very insightful talk. Lots of key things discussed there. I don't know whether you saw at the beginning of Dr. Unscherman's talk, but a lot of GPST1s, pre-GP training, who are about to start next year, ST2s and a couple of ST3s are currently. So I think it's very important for people to understand how to prevent a complaint from escalating, and then once you receive a complaint, how to manage it in an appropriate manner to prevent things from getting worse. So I think that talk was very useful, Rob. Let me just have a look at a few questions. Right, okay. Someone's asking, when a complaint comes in, is it best to speak to your indemnity organisation as soon as it happens, or should you try to deal with it first?
No, I think it's often worthwhile taking some advice from your indemnity provider, because I think it's a chance to talk it through, have a what is it the patient's unhappy with, and trying to focus on that side of it. So no, I think it is worthwhile getting advice. I think sometimes people try to do everything themselves, and it can often be, as I say, quite an emotional thing to have to deal with. So we would certainly encourage you to pick up the phone, and probably, I mean, again, it would be worthwhile if you're in a training setting, again, to share it with your trainer and say this has come in. You get a bit of support, but also just to kind of talk it through and think about, okay, how are we going to address it? We're going to get the patient in, we're going to, who's going to do that? So yeah, I would certainly say worthwhile trying to make it a bit of a team effort, if you like, rather than internalizing and doing it all yourself.
Yeah, I think often people get worried about asking because they feel that it's a bit over the top. But in reality, sometimes you need a bit of calm sounding advice when you're probably at your most stressed during practice. Sorry, Emin, you were going to say something.
Yeah, firstly, thanks, Rob. Great talk as always. Really clear practical points. I think in GP training, complaints is a big thing at the moment, and there's lots of talk around balance between defensive medicine and non-defensive medicine. And I'm just interested to get your thoughts on that term, defensive medicine, what it means to you, and
yeah, no, I think it is interesting, and a lot of there's been a lot published about it. This idea that the fear of being complained or sued, drives you to either undertake tests that you wouldn't otherwise do, or refer people when you wouldn't otherwise. And I think that it's not in anyone's interest, not in the patient's interest, not in the doctor's. And I think that's why the more you can involve the patient in the journey and the discussions about it. So, and yourself, any of us who've been in practice, you're talking to a patient, trying to reassure them. Because I think, one of the big challenges in general practice is that we're seeing disease often in its early stages when it's purely differentiated. And potentially just about everybody you see could have some unpleasant condition lurking. Clearly the vast majority won't, and you can't investigate everybody, but people will worry, especially nowadays where they've got far more ready access to information, and people will be concerned that some vague abdominal symptomatology might be signs of malignancy. But I think I think that's what I was talking about, working out, why is the patient here? What is it you're worried about? Whereas if you just say, oh, stop making a fuss or whatever, there's nothing, off you go. Should there be problems? I think if you hit it, fair honest, and say, look, are you worried that you might have cancer, or are you worried, whatever? And if the patient says yes, you could then have a discussion and say, well, I really don't think that. So, but, we can do this, and almost have that. And I think often the term consent is used in a bit of sort of we tend to think of it about something before surgical operations, but actually when you look at the survey material for patients, the concept of consent is much more about involvement and the idea that doctor talk to them about it. So if you decide that it's unlikely there's a problem, the referral's delayed, and the patient then gets worse whenever you do decide to refer, and if it does turn out they do have something more seriously wrong, I think if they can look back and say, yeah, we talked about it, we made that joint decision, they're much less likely to complain in the first place. And equally, if they do, you've got something to go back and you say, well, no, we did talk about it. I've got that recorded. And again, I think people looking at it from the outside say, well, that's entirely reasonable way of going on, rather than just over investigating and over referring.
Yeah, really good points there. And I think it's a fear that it's not going to go away, is it? People are going to always worry about complaints. It's just a natural part of sometimes being a consultant, but how you deal with it, and almost expecting that it's going to happen at some point is probably a way to diminish the fear a little bit, somewhat.
Yeah, I think so. And I think it really is, I suppose, a reflection of how society is developing. People are more likely to say have information, but also to stand up for their rights. I think the days where people were deferential to all professionals, not just doctors, but to
Yeah.
lawyers and accountants and so forth. And I think we are all now in our everyday lives much more likely to challenge people if we feel that our expectations aren't being met or that we're not comfortable. So I think you're right. Rather than thinking patients don't love me and seeing it in a sort of emotional level, just saying, well, this is an adult to adult conversation. Let's deal with it.
Yeah. Pooja, any other final questions you can see?
No, not really, Rob. I think very sound points. I think often, I know when I got my first complaint as a GP trainee, it totally floored me. And sometimes, as you said, being prepared for it. I think as medics, we're very used to being high performing individuals, and sometimes we take complaints a bit too personally. So I think it's very important to sometimes have those open conversations with the team, with your supervisor, and seek some advice. And that's what indemnity organisations are there for, really. So I think it's always helpful to have you on board, Rob, to give this talk. Because, I think complaints is a huge factor contributing to the workforce crisis at the moment. And I think it's part of that sort of off the cuff term that's used now, resilience, but it is very important to know how to deal with complaints directly, and sometimes we're not taught that in our training. So appreciate your time on a Saturday, really do.
Pleasure.
And as we've
Thank
said,
you, Rob.
Yeah, thank you, Rob. There's more information from MPS in the chat. Please check out the information provided by them. They provide lots of training courses discussing things such as communication skills and helping you with your training. So please check out that link. It will certainly help you out as trainees. But have a great Saturday, Rob. We really appreciate it.
Thanks very much.
Thank you.
Thanks, Rob.
Enjoy the rest of your day. Bye now.
Bye-bye.